Good everyone, my name is Navneet, Anand from Aajkal, local and global. Today we will be talking one of the disease that sometimes takes a life away from the loved ones as well. Yes, we'll be talking about aortic stenosis today. Dr. Anil Aggarwala. Anilji, welcome to the show.
Thank you, Navneet.
At the very beginning,
Yes.
tell us something about this disease which is known as aortic stenosis.
The aortic valve is the valve which actually is on the outside. Well, the valve which is leading out from the heart. So normally this valve is made up of three little petals, like three little leaflets. And when you get wear and tear of those leaflets, the valves then get tethered together so they don't open normally. So they get a bit narrowed. So stenosis means narrowing.
Right.
So this means you get narrowing of that valve. So it's a common problem of aging. Obviously, once you get into your 75 and above, for example, then maybe 13% of the population will have some significant degree of aortic valve stenosis. At a younger age group, 65 to 74, we're talking about anywhere from 3 to 5% maybe of people will develop aortic stenosis. It doesn't always have to be severe. So not everyone who has aortic valve stenosis is going to need surgery, but they're going to need close monitoring.
Right.
So once it becomes moderate or severe and becomes symptomatic, then I think they're leading down towards the pathway of probably surgery, or in an older age group, maybe some of these newer technologies like the TAVI valves and things like that.
Listening to this, I'm already a step back. Is it life-threatening at all?
Very much so. If someone has severe symptomatic aortic valve stenosis, if you leave it untreated, the 5-year mortality is 50%. So
Okay.
50% of them are probably not going to be alive at 5 years, and that's, mind you, untreated. So now, what can you do for these valves? Certainly, the symptoms that patients normally get are shortness of breath, or they get, chest discomfort, they get fatigue, they get tiredness, they can get rhythm problems, and some of the patients who have sort of, a severe degree of stenosis can die suddenly. They have fainting episodes or what we call syncope, and that can be fatal.
So how do we assess the seriousness of this?
Well, there are a few ways. You try and gauge it with symptoms to some
Right.
extent. So how much shortness of breath they're getting, what their exercise tolerance is like. The critical thing is having a listen to their chest. Normally they're going to have a heart murmur. So this is where you really need to have a very good general practitioner who's going to be able to pick up those heart murmurs, and then be wise enough to say, look, this is an issue. We now need to refer this patient to a cardiologist or refer them for an echo, an ultrasound of the heart. The ultrasound is in fact what's going to tell you the true severity of the valve. Clinically, you can tell. We as cardiologists can by listening to chests and examining a patient can get some feel for whether it's mild, moderate, or severe. But an ultrasound will be able to document for you. We measure the gradients across the valve. We can work out the area of that valve. And like a critical aortic stenosis, the valve area becomes less than about 0.6 centimeters square. Whereas mild narrowing of a valve is between 1.2 and say 1.8 centimeters square. So we can actually work out the gradients, we can work out the valve area, we can see how much thickening there is of the heart muscle, we can see how enlarged the aorta is. So the ultrasound is an absolute critical part.
I think it's the wealth of experience that you have as a cardiologist to figure it out, what the problem is, how severe it is.
Sure.
Not only that, I think it is the GP has to be trained on this particular thing as well too?
100%. The GP has to be on the ball, and they have to be on the ball. And this is why it's very important when patients go and see their general practitioners, any doctor for that matter, they should have their blood pressure checked, they should have their pulse felt, they should have they should have the chest listened to, the front and back. So an examination is very important.
So what could be the common cause to have this?
Okay, so there are 4 main causes of
Right.
aortic valve stenosis. One is just aging.
Okay.
You get, so if you get aging, you get calcification of that valve. And that's normal wear and tear. Now, not everyone who gets wear and tear is going to get stenosis.
Okay.
But when there is more wear and tear, you get more calcification, you get tethering of those leaflets, so they don't open as well. So you get the narrowing. So that's probably the commonest cause of aortic valve stenosis. The second one is this congenital condition that I've called,
Right.
which is the bicuspid aortic valve. So that is usually you're born with that. And as I said, maybe 1.3, 1.4% of the population. So the third one is it's a condition we don't see that often, but people who have had rheumatic fever, our part of the world, the Indian subcontinent, for example, or the Pacific Islands, things, Numia, those sort of places, they've had high incidence of rheumatic fever historically. So once you have rheumatic fever, that causes increased damage to the valves. So not just the aortic valve, but the mitral valve and other valves. So that can lead on to premature sort of aortic stenosis. The fourth condition that we have to keep in mind is people who have radiation therapy. Someone who's had lung cancer, for example, or they've had other malignant conditions and they've needed to have radiation therapy because that causes more scarring of those valves. So they're the 4 predominant conditions. There will be other things. Someone's had an infection on a valve and that's caused some damage to the valve. That can cause it. But the 4 main ones are wear and tear due to aging, bicuspid aortic valve, which is congenital, radiation therapy, or rheumatic. If you're getting chest pains which are unexplained, don't ignore them. I mean, don't just assume that it's an aging process. Have it looked at. Go and see your general practitioner. Have your blood pressure checked. Get them to have a listen to your chest. If there's a heart murmur there, have it investigated. If someone comes along to you and says, well, it's just an innocent murmur and your symptoms are due to weight gain or your fitness or whatever, well, you haven't lost anything. At least you can do something about it. But if you do have stenosis documented, aortic stenosis, then it is something that's going to have to be monitored for the rest of your life. As I said, surgery is one option. In the elderly population, someone who is not a good operative candidate, then the Stavi valve, which is all done through the groin and sort of done percutaneously.
What I've heard, these symptoms are often mistaken as the common signs of aging.
Yes.
Does it get really, really worse with the age?
It does progress very much so, and that is one of the reasons why it has to be monitored on a regular basis. Some people may progress slowly over 20 years. Another patient might progress slowly over 2 or 3 years. So they have to be monitored very closely.
Once again, I urge the audience, especially the aged one who are 70 plus, go and get yourself regularly checked up with regular intervals.
Very much so.
We talked about treatments that to be taken for the severe aortic stenosis.
Yes.
What are the precautions that one need to take?
Well, I think again comes back to a healthy lifestyle. No smoking, making sure your blood pressure is under good control, diabetes is under good control. But at the end of the day, once you've developed aortic valve stenosis, controlling these risk factors is not necessarily going to slow down the progression of that disease. I think by managing this obesity, managing these other things, you're controlling your other things that are going to cause adverse outcomes. But once you've developed aortic valve stenosis, there is really not much you can do to influence its progression. I think it really, again, comes back down to having it monitored closely. If you've got severe stenosis, you may need to be checked every 6 months to 1 year. You've got mild stenosis, then you may need to be checked up every 3 years with an ultrasound. That doesn't mean you don't have it checked clinically. Your GP should still be checking it much, much more frequently than that.
What if someone's loved ones are having the symptoms?
Yes.
the first action to be taken by them?
Well, I think they should go and see their general practitioner. They shouldn't ignore their symptoms. You know, as I said, if the GP finds nothing, well, they haven't lost anything. But if any, chest pains, undue shortness of breath, undue fatigue, or there's a change in symptomatology, if you were, feeling a certain way and within 3 months, 6 months, you feel there's a change in pattern with your symptoms, you should have it checked. Have a blood test, have someone listen to your chest, get an ECG done, maybe get a chest X-ray done, have a checkup. It's a basic checkup that's very important.
With your permission, would you allow me to get one of the patient who was
100%.
treated and
100%.
is recovered? He's already recovered from this situation.
Yes.
Is it okay for me to bring him in?
Very much so. I think we'll have some good insight into what the treatment's about.
I would be inviting Mr. John Hale
Yes.
to be here in the studio with us
Yeah, we
to
could.
talk about the situation that he was going in and
Yes.
what he's feeling after the recovery.
I think that'll be useful information.
Thank you so much, Doctor, for letting me invite Mr. John Hale here in the studio.
Yeah,
Welcome
thanks,
to the
John.
show.
Thank you.
Tell us something about yourself.
Well, been electrician for over 50 years, mainly working in the last 20 years has been spent at Westmead Children's Hospital doing maintenance and additional works there. Got a nice son and a daughter and a very supportive wife. And my parents, unfortunately, have passed away, but they were very good to me as well.
I think you would have been wonderful to them as well.
Well, yes, I think they considered me all right, yes.
So you have gone this issue of aortic stenosis.
Yes, I have.
What was the life before the procedure?
John had this bypass 22 years ago.
Okay.
And then been monitoring things, and then the grafts have been fine, but his valve's been getting progressively worse. And then we got to the stage about 5 years ago where he had quite severe narrowing of that valve. He had critical stenosis. He couldn't leave it because if he had left it alone, he would be at very high risk.
With you being in the picture, looking after his health, diagnosing at the right moment and giving
Yep.
the procedure that was required to be done instantly.
Yes,
How did you feel after the procedure was done? What was the first reaction?
I felt very relieved that I could look forward to a whole lot more years of continued life rather than having them stop short.
I think rather than having a continued long life, it's a healthy life as well.
Yes,
Tell us the recovery process that you have gone through.
well, it was the recovery process from the valve replacement was completely surprised me because the valve replaced was on the Tuesday and I was home again on the Thursday of the same week.
Okay, so 48 hours.
Yeah.
Well, some people get discharged 24 hours later. He's probably much healthier now than he was, I would suspect, 7-8 years ago.
Let me tell you, Dr. Anil Aggarwala, you are one of the asset that Australia has. Taking a decision then and there instantly, saving a life. It is not only one life you have sold. Emotionally, there are a number of people who would be attached in the family
100%.
to John.
100%.
Yeah.
So, as I said, when a decision is made, it's an extensive process. It's not just I decide John needs it. Then, we have to refer him to the right person
Yes.
to do it, because you don't want to be sending it to anyone. You want to send it to a person you have confidence with. You have confidence in their expertise and things like that. And even once they get to that stage, there is a multidisciplinary team. So it's not just one person making a decision. There's a geriatrician involved, there's a surgeon involved, there's a neurologist involved. So they've got to sit down on a round table and decide who's going to pass the gate and who's not. There are going to be some patients who are just not going to be candidates even for TAVI valves. But in today's climate, I think if a cardiologist decides you should be, I think most people would cross the goalpost. But we still have to be selective. You have to have a combined team approach.
Coming back to John,
Yep.
what is the most important outcome that you have designed for and achieved after the procedure? What would be your message to the people?
Please do a check, get it see your cardiologist, even if you don't have symptoms. If you're at a stage where in life where you haven't had your heart checked for a while, please do it, because I didn't have any real symptoms. I was relying on my cardiologist to advise me that it was something was necessary. And so, once again, if you haven't had your check, please get it done. It's could be an extended life for you.
Doctor, final words from you.
Well, I think John is a perfect example. You know, I can assure you, if he hadn't had that valve done, he wouldn't be with us today. You know, when people have and you know, John does mention that usually we use symptoms as a guide, but the symptoms are not the only thing. You know, as I said to you before, we do regular ultrasounds on patients who have aortic valve stenosis. It is the change in pattern. You know, if you can see the gradient is getting worse. You can see that the heart muscle wall is becoming thicker. You can see that the heart muscle is becoming sluggish. So these are all indicators that even though you may be feeling okay, you know, there is end organ damage. You know, the things are progressing. So if you leave things alone in that setting, you're not going to be doing a good service to your patients. So if they have symptoms, that makes the decision much easier. You know, then you're doing it, you know, for symptomatic relief and for prognostic reasons. But look, I think the climate is changing. You know, TAVI valves are certainly here to stay. You know, that doesn't mean there is no role for surgical valve replacement now. If someone has coexistent blockages of the arteries, then a surgery is still the preferred option, because then they can bypass the arteries at the same time. John was fortunate in that he didn't really need another bypass. He needed a valve done. So for him, the TAVI valve was a perfect choice, you know, in that setting. So look, I think, as he says, have a checkup. Make sure that your GP is listening to your chest. They're checking your blood pressure. Look after your other risk factors. If there's a change in symptomatology, make sure you have it checked out.
Look, thank you so much to both of you to coming over the studio.
My pleasure.
Maybe with this awareness that we are trying to generate, we can save few lives that would give happy life to rest of their loved ones as well.
100%.
जी हाँ, आज हमने की जॉन और डॉक्टर अनिल अग्रवाला से बातचीत और मैं आपका नवनीत. Thank you so much.